Welcome to today's webinar. My name is Dina Johnson from JFK Partners at the University of Colorado School of Medicine. JFK Partners and the Colorado Title V MCH program collaboratively present a quarterly educational series to address the current Colorado Title V MCH priorities and emerging issues. This series is intended to expand the capacity of the maternal child health workforce and related systems to better serve infants, children, youth, including those with special health care needs and their families. Feel free to type questions or comments in the chat box at any time. Please be sure to keep your microphone muted so we do not hear any background noise. We are recording today's event and we'll archive it on the JFK Partners website. We have already posted the handout for today, so you are welcome to print or save for the future, and I will put that link in the chat as soon as we get going here. Following the webinar, you will receive a link with a survey and evaluation questions, and you may request a certificate of attendance in the evaluation. At the bottom in your controls, you do have the availability of captioning if you would like it by clicking on the transcription button. So today's topic is improving systems to support early identification of developmental delay. And starting our webinar today is Eileen Auer-Bennett. As the parent of a young adult that had multiple disabilities, Eileen has been closely connected to family leadership efforts that focus on helping families make informed decisions when accessing developmental services. Eileen has led the efforts of Colorado Assuring Better Child Health and Development, or ABCD, for 15 years to enroll all Colorado's children so that they can reach their maximum developmental potential. Her professional experience includes supporting healthcare and community partners to create systems to ensure all children have equal opportunities for routine developmental monitoring, screening, and connection to appropriate services. As executive director, Eileen has positioned ABCD to be recognized by funders, policymakers, and state and local agencies as the expert in promoting optimal early childhood development in healthcare and community settings. Eileen envisions a different Colorado where all children with social, emotional, and developmental needs are identified by age 5 to ensure they will get help when it matters most. So Eileen, I hand it over to you.
Thank you, Dina, and thank you everybody for joining us. I can't see everybody's name, but those that I'm seeing, it's nice to see some familiar faces and names and appreciate some of our healthcare providers joining us today. So we're excited to share the findings today from a recent needs assessment that helped us understand the opportunities for improving the early identification of developmental delay, as well as we will hear from healthcare and community partners how they have worked together to specifically ensure our non-English, non-Spanish speaking families have equitable access to developmental screening and services. Hopefully you all, if you registered, you should have received the brief, which summarizes the Colorado Early Childhood Screening and Referral Policy Council's work this last year. And we encourage you all to take a look at that as a summary. Some of that will be summarized in today's presentation. With that, I'd like to introduce our first presenter, Dawn Magnuson. Dawn is an assistant professor at the University of Colorado School of Medicine. She is a pediatric physical therapist with additional doctoral training in population health sciences and health disparities research. Much of her research centers around working alongside community to understand and address barriers to early identification and intervention for young children with developmental concerns. So with that, I will pass on to Dawn and start her slides.
Great. Thank you so much, Eileen. And thank you all so much for being here this morning. We appreciate you sharing part of your time with us this morning. So for this portion of the webinar, I'll be sharing work that we've undertaken through the Colorado Developmental Screening and Referral Policy Council with additional support from AUCD and the CDC. Next slide. Our hope is that through at least the first part of today's webinar, really our goal for this segment is to review key findings from the Colorado Needs Assessment, looking at key gaps along the early identification to intervention pathway. We'll also reflect on some of the barriers as well as opportunities identified through this work. And then at the very end of today's webinar, hopefully we'll have time to discuss some additional potential solutions in this space. Next slide. So to kind of take a step back, we wanted to provide for you just a summary of the AUCD CDC grants, kind of overall project purpose, as well as specific objectives related to this work. The overall purpose of the grant is really to support early childhood state systems through their Act Early networks, really to strengthen the resilience of and resources for children, families, and communities. The objectives of this particular project, as I alluded to earlier, were really to identify barriers and opportunities across kind of key steps in that early identification to intervention pathway. That includes parent-engaged developmental monitoring, developmental and autism screening, referral, and receipt of early intervention services. Next slide. Here we have a timeline, just a brief summary of activities, both for the past year and for our upcoming year. You'll see that we initiated this project by really thinking about the project scope, as well as reviewing existing data. And this was using national survey data, as well as data available specifically here in the state of Colorado. We also conducted a brief community survey, again, just to get additional information from some of our families who live here in Colorado. Earlier this spring, we presented this work to various practices around the state, as well as the Developmental Screening and Referral Policy Council, to start thinking about, what are the gaps that really rise to the surface in this work, and where do we really want to think about focusing our efforts over the next year. And so that's where we are now. Currently, we've gone through, and I'll walk you through some of the priorities that we've identified in this area, as well as some of the actions we hope to take over the next year. Next slide. So just to provide a little bit of background about this early identification to intervention pathway, we think it's important just to remind folks that according to national survey data, nearly 1 in 4 children under the age of 5 years is at risk for experiencing developmental delay. And as we can see in this figure, we can see that the developmental trajectories for a child with what we might consider typical development. We also have a trajectory for a child perhaps with moderate delays and a child with severe significant delays. And we can see that in some cases, these gaps can actually widen over time. And certainly in many cases, these gaps persist. Next. I don't think it's a next slide, but it's an animation. Thanks, Eileen. And so again, we know that these delays persist and in some cases can worsen, which further contributes to health disparities and poor health outcomes later in life. Next button. Unfortunately, the data also tell us that this risk is greatest for children with limited social and financial resources, as well as our racialized families, so including our families who represent Black and Indigenous communities of color. Next slide. And so if we kind of look again at each step of that early identification to intervention pathway, our needs assessment produced a few key findings that we'd like to share with you at this point. When we look at developmental monitoring, parents reported that their primary sources of developmental information included their pediatrician as well as their child care providers. What was interesting to note here is that 20% of respondents reported not receiving any information about their child's growth or their child's development. Now, that's not to say that information wasn't given to families. That's just what families are recalling during those encounters. So that's kind of, again, a 20,000 foot view of our findings in this space of developmental monitoring. If we go to developmental screening, we know that here in the state of Colorado, about 45% of caregivers recalled a developmental screener being completed in the last year. And again, we want to emphasize this is what caregivers are recalling based on past encounters for the last year. What's also interesting to note here is that we can start to see pretty significant racial, ethnic, and socioeconomic disparities when we look at who's recalling a developmental screener taking place. So you'll notice in the graphic on the left, about 36% of children whose families identify as either Black or Hispanic recall, again, their child undergoing some sort of developmental screener, whereas that number is slightly higher, almost double in our families who identify as white. And we also see pretty significant disparity if we look at the kind of insurance that families have, which we often use as a marker of socioeconomic status. So again, kind of key big finding in this developmental screening bucket. If we move on to referral, we know that here in the state of Colorado, 40 to 80% of infants and toddlers with concerning screeners are referred to early intervention. And once again, we see a few disparities in terms of families reporting any difficulty they have in getting those referrals. Where again, our families who identify as white, about 4% of those families reported some sort of challenge. Whereas if we look to our families who identify as Black or African American, nearly 20% of those families report challenges getting those referrals. And finally, if we look at service use, so those children who have been referred and evaluated and kind of have made it that far in the process, what I want to point your attention to, and I'm using my cursor on my computer, like you all can see me. So I'd like to draw your attention to, if we look at this pie chart, we see a green piece of the pie, which suggests what basically what this pie represents is of all the children for the years 2018 to 2019 who were referred for early intervention in the state of Colorado. And so the big piece of pie, the gray piece of pie, indicates that the referral is in progress, it's active or enrolled. And so again, the child and the family made it all the way through the process and are currently receiving services or somewhere along that pathway. If we look at that green piece of the pie, that represents children who ended up being in the wrong service area. So hopefully they were kind of connected with the appropriate agency. Kind of the teal, the lighter blue teal color were those children who were not found eligible for the services. And so those cases were closed. What I want to do is draw your attention to these last two pieces of pie. It's kind of a dark blue and a dark teal. Those pieces of pie represent about a third of referrals here in the state of Colorado. And those referrals were closed either because the family refused to participate in services, refused services, or were lost to follow-up, meaning attempts to contact them and call them were unsuccessful. And so when we kind of look at the big picture, it's a pretty significant number of children and number of families who again kind of fall through the cracks here and are not evaluated or using services that could potentially benefit from those. Next slide. So what we have here on this slide is, again, just kind of summarizing that data in more of a tab form. I'm not going to go through this slide. It's just a different way to look at the information. But again, the key point here is that about a third of families are do not enroll in services or complete the referral either because they're lost to follow-up or they decline services. Next slide. When we look at families who tried to enroll, whose responses are reflected by the dark blue bars here, compared to families who did not try to enroll, whose responses are reflected by the gray bars, we notice a couple of significant differences. So again, of those families who tried to enroll in early intervention, they reported challenges with long wait times. So if you look about halfway down this graphic, those families, again, who tried to enroll in services reported challenges with long wait times to get services. And they were also just really confused by our systems, which probably everyone on this call is perhaps not surprised by that. It can be really tricky for families to navigate our various service systems. So again, those are families who tried to enroll. Among those families who did not try to enroll in early intervention services, they cited issues with potential limitations due to cost of services, which is interesting because for many families, early intervention services would be offered or available at no cost or a very low cost. So potentially some issues with marketing or communication or awareness around services. These families also reported having limited or no services in their communities, and we're also concerned about missing work days or missing pay. So again, those were kind of the key pieces that stood out for those families who did not even try to enroll in early intervention. Next slide. I see there's a question in the chat. For that particular survey, that was about, that was the ABCD survey. I believe that was about 40 to 50 families from around the state, if memory serves me correctly. Thank you for the question. So we know, so when we kind of, again, take this step back and look at the big picture of that early identification to intervention pathway, we certainly see that children and families are falling through the gaps at each of those key steps in that pathway, but that there are also some pretty significant racial, ethnic, and socioeconomic disparities that begin to emerge. As we all have discussed these data, we're also wondering if there might be some geographical disparities as well, but that's just not something we were able to assess with these data. But when we look at the mechanisms underlying the disparities, again, along this early identification to intervention pathway, we know that the mechanisms underlying these things are varied and complex, as this particular figure suggests. I'm not going to go through this entire figure. You should have access to it in your handout. But when I kind of look at barriers and challenges, I like using kind of a socio-ecological model to understand what are the key issues at the level of the family, our clinicians, our organizations, and maybe societal levels. And so you can see here that at the level of the family, things like caregiver knowledge and beliefs, family values and priorities, as well as chronic stressors really influence families' abilities to engage along this early identification to intervention pathway. That's what much of our previous research has shown. If we kind of go up to the level of society, we also know that in many of our communities, there's substantial stigma around having a child with developmental concerns. Many of our families have experienced discrimination or historical trauma, again, that also influence their ability to participate. And so these factors are numerous and complex. We certainly don't have time to walk through them today, but I think these things will help support our solutions and our efforts moving forward if we are able to integrate some of these underlying mechanisms. Next slide. So again, in the couple of minutes that I have remaining, next slide. So again, when we presented these data to folks around the state, as well as the Developmental Screening and Referral Policy Council, really the thing that stood out is, we're losing about a third of our families, a third of our children because of families declining services or families being lost to follow-up. And, we're all very concerned about the significant racial, ethnic, and socioeconomic the importance of early developmental milestones and the caregiver's critical role in developmental monitoring. What we hope to do in this space is to summarize existing initiatives. I know many of you on this call and folks around the state have been working on these things. And so can we begin to collect these messages and develop kind of a unified message around the importance of developmental screening and monitoring and launch some sort of formal communication plan. Next slide. Our second goal really focuses on behaviors. And so here we want to foster very meaningful conversations and shared decision-making between our caregivers of children with developmental concerns and early childhood professionals. And so a few activities in this space include providing additional decision support, again, to both clinicians and caregivers, bolstering our family navigation programs, promoting universal screening. And then also it's important that we're able to track what happens to the referrals as those go through the system. And so really strengthening our referral tracking system so we can better follow children and families through these steps. And then finally, our last goal, if we go to the last slide, is kind of a culmination of all of these things. And really the goal here is to reduce disparities in developmental screening, referral, and service use by at least 20% with these activities. And so that kind of concludes the overview of what we found through this work and also where we hope to head next. So thank you.
Thank you, Dawn. And that's a lot of information, and a lot of that what is included in the brief. So, and I couldn't tell because I didn't want to navigate to chat, but we had 125 survey respondents, if that was the question, about how many people responded to the survey that this data was taken from. So thank you, Dawn. Now we get to hear from Dr. Christy Canuti-Rodriguez and the work that Denver Health is doing. Dr. Rodriguez is an associate professor of pediatrics at Denver Health Pediatric Emergency Department and Urgent Care and University of Colorado School of Medicine. Through a series of grant-funded research and patient care initiatives over the last 6 years, she has built and oversees the Denver Health Refugee, Immigrant, and Migrant, or RIM for short, navigation program, which provides culturally and linguistically responsive care navigation for RIM patients. And with that, Christy, I will go back to your presentation. Maybe.
And thank you so much for having us today to talk about the work we're doing at Denver Health and with our community partners. This is the previous presentation, actually, I think is a good segue into our work. It's an example of work to address some of the disparities that we are seeing in the community that we work with, which is our RIM, refugee, immigrant, and migrant population at Denver Health. And our work in developmental screening has specifically is specifically focused on our non-English, non-Spanish speaking children, and I'll explain why in just a second. So I'm just going to briefly talk about primarily our developmental screening data from our project, and then we'll move into the panel portion. Next slide. So our work started several years ago when we identified a disparity in developmental screening and surveillance for non-English, non-Spanish speaking children at Denver Health. So we compared English, Spanish, and non-English, non-Spanish, and looked at both screening. Denver Health at the time and now was using the Ages and Stages questionnaire for screening, and also surveillance. So asking questions about the child's development in well child visits. And we found that there was a disparity for both screening and surveillance for the non-English, non-Spanish speaking population. And that's what led to this work. If you could go to the next slide. So why culturally responsive navigation? And I'll talk a bit about our RIM navigation program, which is a culturally and linguistically responsive navigation program. So we started our RIM navigation program after we did a series of focus groups with African immigrant and refugee community leaders and members. And I think especially this first quote, but both of them to me really speak to why we developed the program and why I think it has been an effective strategy for addressing the disparity in developmental screening that we identified. So we trust our people more than other communities, more than other persons. I can explain my problems fully to the person who speaks my language, and I know that he belongs to me. And we can go to the next slide. Thank you. So this is our refugee, immigrant, and migrant navigation program. We started officially this program in 2015, and we currently have me and then Betsy Ruckard, who's our refugee services coordinator, who is just the day-to-day operator of this program. And then we have language. And the first is Adrian Matadi, and he speaks Amharic, Arabic, French, Lingala, and Swahili. Kwang U, who is one of our panelists today and who I'll introduce in a second, but he speaks Burmese, Karen, and Po Karen, and Rasulo, who speaks Mai Mai and Somali. And they were all themselves refugees and then have worked for years in the community and actually all of them now for years as RIM navigators at Denver Health. Next slide. Oh, and back. Okay, so this is the project timeline. So we started, as you can see, back in 2017, and we initially trained the 3 navigators in basically every ASQ between 8 and 48 months, and specifically went through the questions and what developmental concept the question was asking. And we did the same thing with the SWIC. And then we did some PDSA cycles to decide on if we wanted to use the ASQ or the SWIC for our pilot to improve developmental screening for our non-English, non-Spanish population. And you can go to the next one. And this is just an example of these culturally responsive adjustments that we made as a team with our navigators' expertise to how questions were asked. So there's a couple questions on the ASQs about if a child can pick up Cheerios or a crumb, either looking at pincer grasp or at the raking motion. And this is just an example of what one of our navigators found for different populations that he was working with, but not so many people in the community knew about a crumb or a Cheerio. And so he would use rice as the example because it's a similar size, but more understandable to the patients he was working with. And another, next slide. And then this is another example. So when you ask, what is your name? Does the child say both her first and last name? And as this is Kwang's example, but as a Burmese, for Burmese children, he marks yes if they say that the child knows his name, because they don't use first and last names, it's a single name. And so there's not a way to further score that question besides indicating that for the child's culture and community, they know their full name. Next question. Or next slide, sorry. So we had several partners and collaborators on this work. They are all listed here, but it's our RIM navigation program, and then ABCD, Tri-County Health Early Intervention. So we're partnering with Rocky Mountain Human Services, Developmental Pathways, and Denver Public Schools. And we're really lucky to have a couple representatives from those, from all of those partners on the panel. So we'll get to hear from them. We also worked closely with Lowry and Westside Family Health Centers at Denver Health, and then with the Epic Champions at Denver Health, which is our electronic medical record. Also the Public Health Institute at Denver Health. We also worked at the time with Colorado African Organization, and then with Aduca Radio to get messaging out about how developmental screening is a regular part of well child visits, similar to vaccines and other things that are checked at well child visits. And then the Launch Together initiative. So in January of 2018, we started radio shows, which were conducted in several languages, and our navigators did the majority of those. And then we had an interpreter for some of them, but they were conducted in several languages of the refugee and immigrant communities in the Denver metro area. And they were interviews asking questions about why developmental screening is important and what is to be expected with developmental screening. And we focused on it being a way for to make sure that kids have what they need to be ready when they go to school and have the resources they need while they're in school. And they were broadcast. They have like a live broadcast of them, but then also on Facebook Live, and we're actually very highly viewed, and just as a way to normalize developmental screening. And then we worked with Colorado African Organization with their community health workers to do outreach into the refugee and immigrant communities about the kind of normalizing developmental screening. Next slide. And then we began our pilot at Denver Health to improve how often our families were having the ASQ done, and to fix that disparity. And so, and the next slide will be an example of that, the data from that, and how we did that. So what we did starting in 2018 is when non-English, non-Spanish speaking families would come to Denver Health's Lowry Family Health Center, and who were between the age of 8 and 48 months and were there for a well child visit, then we would have the front desk notify one of the NENS navigators that the family was there, and the NENS navigator would then, or we call them RIM now, but the navigator would come out to help the family with the ASQ and to go through the questions with them. And they would also talk about why we do it and why developmental screening is important and a part of routine well child care. Next slide. So we collected demographic and ASQ completion data for the NENS children in this project who were offered the assistance from the navigator. And we also calculated the monthly developmental screening rates for kids age 8 to 48 months before, during, and after the implementation of offering the assistance from the navigator. And through a retrospective observational cohort system-wide, we also looked at all non-English, non-Spanish speaking children who attended well child visits between age 8 and 48 months during that time frame. And then we compared those that were offered assistance with the ASQ to those who were not offered assistance to see if there was a difference in their ASQ completion rate. Next slide. And what we found was that during that, it was a little bit over a year that we were collecting this data. There were families of 341 non-English, non-Spanish speaking children who were offered ASQ assistance at a well child visit by the navigators, and 77% they were offered it at one well child visit, and 23% at more than one well child visit. And the families accepted the assistance 88% of the time. And of those who accepted assistance, the ASQ was completed 98% of the time. And 41% of the time we had family and navigator language concordance. So which means that the family and the navigator spoke the same language. The other times the navigator would use an interpreter phone and still help the family with the ASQ. And the most common languages were Amharic, Burmese, Nepali, and Arabic. Next slide. And this just gets into the results during that time, that initial phase of this implementation. So, and you can actually go to the next slide just to add a little bit. Yes, so you can see at the top our baseline rate for our Spanish and English speaking patients at Denver Health for receiving a developmental screening at their 8 to 48 month well child visits is about 89%. And when we started this project at Lowry for the non-English, non-Spanish speaking children, it was 65%. And we got up to nearly 77% during that initial phase of the project. Next slide. And we've been and then we also during the project showed that this was looking at all non-English, non-Spanish speaking children in this age range coming in for well child visits. And we looked system-wide and found that if children were offered assistance from a navigator, their odds ratio for completing the ASQ was 7.78 compared to children who were not, NENS children who were not offered assistance. Next slide. And we can actually go to the next one. So, so we got up to that 77% during that initial phase of the project. We've continued to follow monthly rates up until when the pandemic started and things got a little more interesting. But this just, I just wanted to show these rates to show we're still seeing improvement in how often our non-English, non-Spanish children are getting developmental screening. And it did drop a bit when the lead navigator for this project, who's Kwong, who you'll meet in a second, was out on leave, just showing how important he is to our project. So since that time, we have been collaborating with many community partners, a lot of whom are on the panel we're about to meet. So we're collaborating with it's a collaboration between our program, the RIM Navigation Program, Rocky Mountain Human Services, Developmental Pathways, Denver Public Schools, ABCD, and Tri-County. And what we found is that while we improved developmental screening, there were still a lot of disparities when we looked at the data for non-English, non-Spanish children getting actually getting through the early intervention services referral process and getting to the place of receiving services if eligible. And so we've been working as a group now to address that. We also had to make some adjustments for COVID. Just in terms of our navigators are working predominantly remotely now because of COVID. And so they're doing a lot of the ASQ assistance remotely. And that will get us into our panel discussion, which I'm really excited about. There was a little contact information up there on the slides, which you'll be able to have access to. I can put my our team's contact information in the chat as well. And that moves us into the panel discussion. So I'm going to introduce our panel and invite them all to turn their cameras on. So we have a panel that includes members of the Denver Health RIM navigation program. And then we also have Michelle Bendick from Tri-County Health Department. And then we have a representative from both Rocky Mountain Human Services and also Developmental Pathways. And all of those organizations were very key to the work that we've been doing and the progress that we've made with addressing the disparities in referrals for non-English, non-Spanish speaking patients for early intervention services. So I'm going to just introduce everyone really quick and then start asking some questions. Thank you for being here. So the first, my first bio is Quang U. Quang U's personal experience as a former refugee has directly informed his deep commitment to working with the underserved and pursuing his ultimate goal of one day becoming a physician assistant. Quang's family fled Myanmar due to ethnic cleansing and ongoing political conflict, and he ultimately lived in a Thai refugee camp until the age of 13 before resettling in the United States. Quang speaks Karen, Po Karen, and Burmese and English, and received an economics degree from Colorado State University in 2016. For the past 4 years, he has worked at Denver Health, the place where he first came as a newly arrived refugee, as a refugee, immigrant, and migrant, or RIM, care navigator, focusing on non-English, non-Spanish speaking populations. And then we have Betsy Ruckard. Betsy Ruckard's personal reality as a biracial adoptee has directly informed her deep commitment to equity and caring for the underserved and under-resourced. She has worked at Denver Health over 9 years, starting as a patient navigator and for the past 7 years as refugee services coordinator. Betsy has dedicated her career to both creating a healthcare workforce that is diverse, as well as focusing on projects to improve person-centered and clinical outcomes among RIM populations. Betsy collaborates with community partners and develops highly effective teams who are multilingual and multicultural. And she manages the RIM navigation program at Denver Health and also the Refugee Medical Screening Clinic. And then we have Michelle Bendick, who is the Early Childhood Wellness Coordinator at Tri-County Health Department. She has spent the majority of her career in Colorado focused on improving developmental outcomes for young children in Colorado. And Michelle is also a Buell Early Childhood Leadership Program alum. And then we have Shannon Banks from Rocky Mountain Human Services. She is their early intervention engagement specialist. And her position was created with the support of mill levy funding to help identify gaps and remove barriers for families in accessing early intervention services and resources to meet the needs of their infants and toddlers. Shannon collaborates with community partners and works directly with families to support their access to developmental evaluations and ongoing supportive services. Prior to starting her work as an engagement specialist, she was a service coordinator in the EI program at Rocky Mountain Human Services for almost 3 years and an elementary school teacher in the DC area before moving to Colorado. And then last but not least, we have Heidi Troutman, who is the Director of Early Intervention at Developmental Pathways. She has over 13 years of experience in the field. In addition to being a member of the Developmental Pathways leadership team for the past 5 years, she has also supported children and families as an early intervention special educator and a service coordinator. So thank you all so much for being here. I did want to briefly say that we also want to thank Colorado Health Foundation, who has been supporting this work that we've been doing to address both developmental screening and also referral disparities for NENS patients. So with that, thank you for being here. I think everyone's got their cameras on. And I am going to start off with a first question, and then I'll look in the chat too for questions as people have them, and we'll try to get some questions answered by the panel. So my first question is, what were the collaborative steps that you all took or made to improve developmental screening and referral for RIM families? And I'd like to direct that first at Michelle Abendick and Betsy Record.
Thanks, Christy. So to make this work happen, it really took collaboration, coordination, and communication. Those three things were essential to getting this work off the ground. So we first started by creating a core group of community partners. This was Assuring Better Child Health and Development and various partners from Denver Health to really be champions of this work. We outlined the steps that we believed needed to happen to support RIM families. And then we began meeting with local CCBs, Child Find programs, and other community safety net programs such as home visitation to really try to get a pulse on what was happening in the community to support child development within RIM communities. From there, we worked internally with Denver Health with their early intervention referral coordinator, with the EPIC team, and also surveyed medical providers and other clinical staff to really understand what was happening for RIM families in the screening to referral continuum. What we quickly learned that for language justice to happen in equity among this population regarding screening and referral, that we were going to have to work more closely with our community partners, such as early intervention and Child Find. And this led us to having monthly meetings with those CCBs to break down these barriers in the screening to referral to evaluation process. And this also led us to start meeting more frequently with internal staff at Denver Health to really start to strengthen the process so that we knew from start to finish the journey these families were going through. Betsy, what would you add?
Not much. That was really fantastic, actually. I think the point really is that none of this work can be done siloed. And so forming relationships, building collaborations, asking questions that relate to everyone, all of that was really key in our being able to address disparities, also sharing the information, right? So when we shared our data, I think that got everyone's collective juices going and saying, oh, how can we address this, these situations? And so, it was really, it's been a real pleasure getting to know people and working collaboratively. And I think that is why we've seen also some of this progress, because we couldn't do it without that. It's one thing to address your own institution, your own internal issues, but when you get to a certain point where that referral gets out of your hands, there's an additional people that need to be involved. And so it's been really helpful to have this collaboration. The other thing that I wanted to mention was just that one of the things that we did for Denver Health was, in all of these larger institutions and people who are working in the community, it gets confusing, especially when you don't either see kiddos every day, or your expertise maybe is, in the whole family and not just the, children. And so I've worked with all of our collaborators and partners to develop guidance, sort of a protocol, if you will, for our Denver Health providers to explain, even just the difference between what the acronym EIS is versus EI versus, Child Find. Some of these things seem like, well, people should already know this, but the reality is that's not necessarily true. And so it's been very, yes, thank you. There's an example of the document right there. And it's been very helpful because we were able to utilize all of our combined knowledge to sort of create this document and then pass it on to the institution. And so there's lots of information, which I think that there's a link to so that you can look and see that. But that was also very helpful. So that's all I have additionally to add.
Mhm.
And then I was hoping to get just some additional thoughts on that question from Heidi and Shannon and Kwong.
So at Developmental Pathways, we championed a team of intake coordinators and leadership to take on the RIM project. We also created a half-page flyer introducing families to early intervention that was translated into our 10 most commonly spoken languages outside of English and Spanish. We also had Betsy and Kwong come educate service coordinators on the best ways to engage families.
Thank you, Heidi. Hi, everyone. This is Shannon from RMHS. We did similar things with Champion, a team of intake and leadership to really guide us in working with our families that were coming through with the RIM project. And Kwong also came and did some ongoing education and support for those coordinators who are making first contact with families. And then we've also been working with ABCD to develop trainings to further explain what the EI processes look like, even after that evaluation, because it is quite a journey that families go on. So making sure that people who are involved in speaking with them about the program can give additional information. If families are hesitant and want to know kind of what's going to come next and what could that eventual result and outcome look like for their child and their families.
Christine, there's a couple questions in chat.
Yes, I was looking at those. So let's see, I'm gonna answer the first one, which was what screening tools other than, or it's the last one actually, what screening tools other than the ASQ have you found to be appropriate for RIM families? Also, is there a way for someone to access the culturally adapted ASQ? So that is a great question. Here, I just realized I didn't start my video. That is a great question. So what's tricky with all of the developmental screening tools I think that are out there is that the validation for languages other than English or Spanish, I mean, it's not validated for, I think they're translated into other languages, but not validated beyond in English and Spanish. And that's true for the ASQ. It's also true for the SWIC, which is another tool that we were looking at. And we found both of those worked pretty well in our PDSA cycles. We ultimately went with the ASQ because Denver Health was already using it and the scoring was more straightforward. And the other reason was because the SWIC asks a question about, do you have concerns about your child's development that is potentially problematic? And we'll just get a no answer, regardless of whether they're, if a pediatrician evaluates that child, if there are concerns. But I do think it's something that needs to be looked into more. We don't have a copy of the culturally responsive tool because it was done as a training with the navigators who are our cultural experts. And so we work with people who speak more than 90 different languages at Lowry Clinic. And so they really have to kind of work in the moment and know what the developmental concept is that the question is asking to then be able to ask the question in a way that the family understands. But we can definitely share some of our examples.
Christy, can I just add to that piece about the culturally adapted ASQ? It really was myself and the navigators sitting down with every ASQ that we are going to be using and going through every single question and determining what is the actual developmental skill it's asking, and what's another way we could ask it in a more developmentally appropriate way for these various RIM families. So it really was a labor of love and going through every single question to identify what is the skill we're looking for and what are other ways that would be culturally relevant to ask that question.
Okay, let's see. And then we'll get into this, I think, a bit with the other question with the rest of the panel, but could you further explain and define what language justice might look like for these families? Does the navigator act as an interpreter, cultural broker, or mediator more than interpretations in first language?
Would you like me to take a crack at that? Okay. That's a great question. Thank you for that. So language justice is incredibly important. There are a lot of times where, and it's more global than just Denver Health, right? It's also part of what we've done with our work group that of the folks that are on this call. So it's when CCBs are getting consents. It's when, and not just the intake process, but every part of the process. For us, it's utilizing our interpretation lines when we need to. It is also utilizing our navigators who have all been tested in the languages that we're able to. Not all languages that they speak are testable, but they have all gone through whatever available tests there are through our language services department, and have all actually been former interpreters. But you're right, they do more than just that. They provide that not so much interpretation as speaking in their own language. And Kwong, when I'm done, please weigh in on this. But so there's both. There's speaking in the language, and then there's also being a navigator. So that navigator is really, that role is really a bridge between the patient and the health system. So that could be the doctor, that could be any part of the medical team. It's also, in this project, Kwong does a fair share of advocating between patient and also the CCBs. So Rocky Mountain and DP, their folks have formed relationships with Kwong, so they have this really great bi-directional communication. So if there's an issue with the patient that Rocky or DP is not aware of, Kwong can contact his contacts there and then try to make connection. And so, but language justice specifically is also us identifying where we think that there are maybe some missed points of opportunity for our patients along the whole system, not just with us. And so that's been a really wonderful, I think, byproduct of this collaboration, is being able to sort of address some of that. Kwong, do you have other thoughts on that?
I think you touched on everything. You already touched on everything. The main thing that I really want to touch on is that, even though I from Burma, I speak Po Korean. I am, my primary language is Po Korean. But working as a Denver Health employee, I'm not allowed to interpreting for the patient. So most of the time I talk, but the good thing is Denver Health allows me to talk to my patient, the people that speak my language, using my language, my prior language, to them, but not so much interpreting for the provider. And even though we have gone through a lot of training, like medical training, but I think that, Denver Health is not, they don't want employees to be interpreting for the patient. I think they just want to, prevent any miscommunication, and especially prevent any miscommunication. And also because we're on grant, so we have, other project that we need to work on, that, interpreting for the provider every single visit doesn't make sense, because we have other metrics that we need to meet. So.
Thank you, Kwang. And that is a great segue into the next question I had, which is what are some strategies to make the screening process for refugee, immigrant, and migrant families successful and at Denver Health, like for that actual developmental screening strategy process? And what do you think was helpful to improve screening rates and get everyone on board?
Yeah, that's really good question. So we did a pilot. We let everybody in. Oh, wait. So we let everybody in the clinic know that we're gonna do a pilot completing ASQ for NANS patients. So what I did was, the day prior, I will scrub the schedule and make or change the note of appointment information so that the front desk can call me when the family comes in to check in for an appointment so that I can come to the lobby, meet the family in the lobby, and get the ASQ completed. So there's time when the family comes in and I don't speak their language. My colleague who speak their language will come help the family in the lobby. Of course, there are times we have, patient that comes in that none of us speak their language, then we will wait until we have an opportunity. For example, we will complete the form in the exam room before the provider comes in using the language line interpreter. And for any reason, if we cannot get the form completed before the provider walks into the room to see the patient, we step out and then let the provider know that, hey, let me know when you're done so that I can come back to the room to complete the SQ for the patient. So the key is, consistently communicating with your front desk, making sure that the front desk know how to contact you, and also be flexible as a navigator, And the other thing is, after the form is completed, we let the provider know whether or not the provider is going to place a referral to early intervention or DP or other CCBs.
Can I just add one thing, Christy? The other thing too that one of the strategies that we did was we were noticing between organizations, between Denver Health and Rocky Mountain and DP, a lot of times we would tell the patient, this is what's going to happen. This is who's going to call you. And then when DP or Rocky Mountain folks would call the patient, they'd say, well, I have no idea what you're calling about, or they wouldn't even answer and say, well, I don't know what that is. I don't know, no, and they would decline. And so then we decided that we maybe needed to look to see what the scripts were, what people were saying, what was Denver Health saying to the patient, what were each CCB saying to the patient. And what we realized is we needed to sort of come together and have some combined messaging. And so Kwang and Michelle and I we worked on sort of creating a template, and now we're working with the CCBs and our whole collaborative to try to look at that common messaging and develop a script that maybe makes more sense between all of the organizations. And so that's been a strategy that we're looking forward to seeing how that works.
Thank you. And Betsy, I put, there's a question in the chat about Afghanistan, patients coming from Afghanistan. So I was going to let you answer that in the chat while we're asking more questions, if that works okay, since you're the expert there. So my next question is for our colleagues at Developmental Pathways and Rocky Mountain Human Services. So for Shannon and Heidi, could you talk a little bit about how the data has changed for the non-English, non-Spanish speaking children that you have been receiving referrals for, in terms of how many of them are getting connected to you initially, and how many are accepting services or accepting evaluation? So if and just kind of ballpark what the data is looking like since we started working on this project.
Sure. So at Developmental Pathways, I think the work that we have done with Denver Health, specifically Betsy and Kwong, has really engaged our families in a different way to see really positive outcomes. So alongside of these shifts in our intake process, like using common language and engaging Kwong as a support with our intake coordinators, we've seen increased referrals from Denver Health overall. And from both the West Side and the Lowry Clinic specifically, we've seen increases in the referrals being made to Developmental Pathways. With those referrals that are being made, we have seen less parents decline participation in early intervention than previous years without the NIN support. And then over 85% of our families that have been referred to Developmental Pathways are making it to their evaluation. And so when a family doesn't make it to their evaluation, it's either the Developmental Pathways intake coordinator or Kwong cannot get in touch with the family. And the main reasons being are loss of contact because the phone's been disconnected, phone number has changed, or there is not a voicemail set up. So we've seen really positive results. Shannon, what have you guys seen?
Thanks for tossing the ball over my way, Heidi, on that. We've also seen some really positive outcomes in our data. The one I really like to highlight is our most common outcome is that we have an evaluation scheduled for a family that is coming through this project that we've been tracking. So that's really, really nice to see. We have seen a decrease in the number of families who we have to close their case for no contact. That typically was the most common reason that a referral was closed, and we've seen that decrease for us. So we're able to get in contact with families more frequently with the help of Kwong and our coordinated and collaborative efforts on that. And we are still seeing some families are declining services prior to evaluation. So if we were to rank our outcomes, we have our scheduled evaluations and then families declining to schedule an evaluation and then closed due to no contact. And we also can see that we have some space too for families who have scheduled an evaluation to make sure that they're completing that appointment. And we still need to do some work on the cancellation and no-show rate. And looking at the data, a lot of that was around the time of COVID and looking at the impact of the pandemic on the completion rates of those scheduled evaluations. But overall positive data moving in the right direction for getting contacting families and having them engage in our process and services.
Thank you both so much. And I think that improvement in the data speaks to how powerful this collaboration has been. And I'm so grateful to both of you and your organizations for being willing to do this work with us, because it's, it takes a lot of effort and it's a lot of meetings and a lot of individual time working together. And I'm just grateful for Developmental Pathways and Rocky Mountain for being willing to do it. Hard work, but good work. Next, I wanted to ask Kwong a question. Could you speak to what it's like to balance your both being a member and a trusted community member in a RIM community, and then also being involved in this work as a representative of the health system and what that's been like for you?
Mea bigo ati pule melagi wa pemicume kucing ati takut kucing ati weda jebama luto ati bigo ati nama klan aku cuma benar.
How did everyone feel about Kwong's answer to that question? How did it make you feel? So we thought that this, and thank you, Kwong, for doing it. We, as a team, thought that this was an important chance to point out how confusing and disorienting it can be when someone speaks to you in not your preferred language. So when someone, even for a few seconds or a few minutes, or just to say one or two things, speaks to you in a not your preferred language and expects an answer back from you. So just a point of why using interpreters is so important, and using medical professional interpreters. Culturally and linguistically responsive care begins with using interpreters. It doesn't end there, but it begins there. So thank you, Kwong, and let's answer that question again in everyone's preferred language.
So developmental screening is good for families. The community that I work with, but families are still worried that their children, the child might be labeled. Um, that is why, I do a lot of educational and over the phone or in person. Sometimes when I go to the temple, if I see family members, come to me and ask question about developmental delay, then I will explain to them how the process works. And at first, it was really difficult doing this work because developmental screening is not a culturally, it's not a it's it's new to us, even new to me. So I had a lot of pressure doing the project, but through doing educational and personal over the phone and meeting family at local event, it helps me less pressure and family appreciate the help that they're getting from me.
Thank you, Kwong. And there's another question in the chat, and I think this could be directed to several people on the panel. Can you talk more about the key messages that help with families following through on the referral? What are they worried about that assures them and starts to develop trust to move forward and positive outcomes for completion of evaluation, et cetera? And you started to touch on that, so I think it's a good time to question.
Right. So, like I mentioned earlier, so a lot of people were worried that we might label their kid as, as uh, um, not worth it. There's a lot of stigma around that. So I have to do a lot of training, and also my other not coworker, have to do a lot of education for his community. So we build trust by educating them every day. Every time when they come in for well child check, we'll let them know that this is something that we need to get it done. As developmental screening need to be done for well child check. So we let them know and what the process like. And we spend a lot of time educating them about the process, and we let them know, because a lot of the time, if we refer the kiddo to external place, they don't really want to, follow up. So we have to let them know that, these people are, they are a friend. We work closely with them, trying to help your family to, to get the care that they need or services that they need, so that they're not behind, when they go to school.
And any other panelists have some specifics of things in the messaging that have been helpful with working with families?
I'll just mention that I think the Educa Radio presentation or information that was provided was really helpful. They were posted to Facebook, and they were on the radio, and there were like 20 questions that we worked on specific for communities who experience the stigma, questions that the navigators themselves had been asked by the communities. And I think that, again, normalizing it, it's time, it takes time. It takes putting it out there in the community. It takes talking to community leaders and getting, faith leaders, community leaders, everyone informed. And so our team has done a really good job of that. And then with the help of Michelle and Eileen, there was all this really great background information and training and education that occurred that then allowed the navigators to sort of take all that in and then figure out how to make that make sense within their communities, and how to also communicate that in a way, because obviously there are some things that you say in English or in the health system that don't, I guess translate, but I don't mean translate, but they just don't communicate well, in other communities. And so there was a lot of very intentional time spent on that. So I think it's a multi-pronged effort. There's radio, there's talking in person, there's talking to providers, there's talking to patients. There's just this it's been sort of a massive effort.
Betsy, would you be comfortable with me sharing screen on the little infographic we did for the radio shows that's talked about children being ready for school?
Sure, sure.
Okay, I'll just put this up quick, you guys, just to see because of the messaging question, because I think it's so good. So this was prepared for the radio show, and just normalizing for families. So just want you to see.
And that infographic was used by the community health workers. We partnered with Colorado African Organization. And so they would kind of go through it in preferred language with the groups that they were working with. And then it also emphasizes some of the key themes of the radio show interview as well. I did want to ask next, what changes has everyone made due to COVID? So how did you shift the work with the refugee, immigrant, and migrant populations during 2020 as a result of COVID-19 to ensure that families and children were continuing to receive screening and to make it into and through the referral process? And we can start, let's start with internally at Denver Health with Betsy and Kwong.
Okay, all right. So pre-pandemic, I was doing, we completing ASQ and in person, like I mentioned earlier before, it was done in the lobby, in the exam room. But during the pandemic, everything is done over the phone. It takes ASQ is very long. For my language, if I get ASU completed in my language, it takes about at least 15 minutes, but using an interpreter, it takes about 25 minutes. So everything is done over the phone. And again, I'll do the same thing, scrap the schedule and contact the family before they come into the clinic for a well track check and try to get ASQ done. And then when ASQ is done, I will forward the score to the provider and the medical assistant that is working with the provider that day, so that the provider is aware of the ASQ that was done. And the other thing, the challenge that I had was, doing over the phone was doable. It's doable, but it's a little complicated. For example, you don't see the expression of the family when doing over the phone, but in person, it's easier. It makes it easier. For example, there are questions, there we have material in the room that I can use, to show the family to get the question down. For example, like colors, we have colors in the room. I will show it to the family, and to the kid, do you know this, what color it is? That's why it makes it easier to do it in person compared to over the phone.
Yeah, I would just say, I think the better question is what hasn't changed since COVID, really. And so, yeah, Kwong and his colleagues, our colleagues, everything had changed about everything. And I think that the biggest change was that we had competing priorities because COVID outreach and then COVID vaccine outreach became really the focus. And so I'm really impressed with the data that we do have during the pandemic, that we were able to continue to do a lot of this work. But I anticipate the data improving even more over the next year, just because so much of what Kwong and the other navigators were having to do was COVID outreach and education, and then ultimately vaccine scheduling to try to, especially with our RIM communities. And so, but yeah, like Kwong said, I think that to his credit and to our team's credit, everything moved remote, which meant technology changes, and how do you help families through their own technology issues and trying to get people set up if they really needed an evaluation and it had to be virtual. How do we connect and work with that? And it was really great that we've already had these established relationships so that Kwong could call and say, hey, this family's really having trouble and needs either an in-person evaluation, if that can happen, or we need to address the technological issues. So that's been a lot of the changes I've seen.
And how about for you, Shannon and Heidi? Whoever wants to take it first.
Yeah, sure. I'm Betsy and Kwong and kind of summed it up with like what didn't change and definitely looking at technology needs. So a lot of work that we did was trying to identify barriers families might experience as early in the process as possible so that we could either adjust, and if an in-person evaluation was a possibility, to do that. If we needed to work on providing technology so a family could access a virtual appointment, making sure we could get that done and have that set up, and even scheduling like practice logins so that the day of an evaluation, the family was already comfortable and had access to whatever the virtual platform that we were using for that evaluation. I think a big part of it too, especially early on in the pandemic, was getting word out to Denver Health. Thank goodness we had such a great, strong relationship and other community partners that early intervention was still up and running. I just still to this day floored of our ability, DP's ability, early intervention's ability just to continue to provide services to families, even though it looked very different and it was mainly done virtually, that we were able to adjust and continuing to support families. So getting the word out and helping those in the community who make referrals, through that process and letting them know what changes had happened because of COVID and what we were able to do to support families. And like Betsy mentioned, the competing needs and priorities. So really looking at early intervention and the supports that we're providing to address some of those other needs like food insecurity, rental assistance, and kind of looking at how we can get those evaluations done and help families that are experiencing a lot of other challenging situations, as we all were going on at that time. And I think Heidi might touch on it too in terms of education about EI, but the eligibility criteria changed as well during COVID. So talking to our partners about that, and then at Rocky Mountain, we were able to create a Denver Early Steps program that could continue to provide services to families that had more of a moderate delay at 25 to 32%, who historically would have been eligible for EI services, but no longer due to the role change, to make sure that those children were still getting support and services.
At Developmental Pathways, we started our work with Denver Health during COVID. So we partnered with them starting in May of 2020. And so all of our interactions and supports have been done virtually. And so like RMHS, getting the word out that EI was open and ready to help was definitely the priority, and making sure families were being served and eliminating barriers that we one of the barriers that we tried to eliminate for families were being able to allow them to connect virtually to engage in EI services. So we provided them with devices so that they could be successful in participating. And then also just with the eligibility shift from 25% to 33%, just educating Denver Health along the way and kind of helping them navigate these EI changes so that they could share those changes with the families as they were making referrals.
Thank you. And then as a next question, and I'd like to start actually with Michelle, if possible. So she's been working with us through the whole project, and she and Betsy have worked really hard on all of the scripting and standard work for this project. And I think she has a great kind of overarching sense of the project and kind of the many moving components of it. So, and then I want to ask everyone else the same question too. But what is one piece of advice or recommendation that hasn't been tried or discussed that you would give to anyone interested in improving access to developmental screening and referral for RIM families? And I'm sorry to put you on the spot, Michelle. I just wanted to acknowledge
that's fine.
what you've done.
I think what's the one piece of advice I would have is to know your why. And our why was that we needed to get our RIM families screened and connected to services at the same rate as which English and Spanish were being connected. And once we had our why and we knew what we wanted to work towards, it was then we needed to start figuring out who else in the community wanted to participate in our why and help these kiddos get connected. So, you know, thinking about some of your non-traditional partners, who is providing home visitation, you know, what programs are at your health department, such as HCP, and providing that care coordination component. And so really having your why and having others in the community on board with that to really collaborate and create this ideally seamless system for our families to navigate and get through from screening, from developmental concern to screening, to referral, to evaluation, and ultimately services should they qualify.
Thanks. And then other panel members, what is one piece of advice that you would give for other people wanting to do this type of work?
The piece of advice that I would have is to engage and learn about different cultures and language. And so we've started this work and we are excited to take a deeper dive, but I think really understanding cultural competency and having trainings around it has really informed the work that we have done with, especially our RIM families, and just being able to be more successful in engaging them in early intervention services.
I would agree with Heidi on that one, learning and educating, and then also taking that knowledge and looking at current processes that might be in place and figuring out what modifications could you do to help families now knowing what you do about language, culture, and the differences, so that, like Michelle said, that it's open and accessible and as seamless as possible.
I think for me, there's many, but I think a lot of it is, I was going to say hire Kwong, but don't hire Kwong. You know, seriously though, I think that it can't be overstated, the importance of including community and making sure that we are providing, you know, pipelines for people to learn new skills and to further their career goals, and in doing so, utilizing their expertise to communicate with the communities that we are attempting to and need to be serving. And so, you know, there are things, I can't tell you how many times a day I go, oh, of course, Kwong, of course. I didn't even think about that because he is the expert and he, you know, knows his community. And, you know, there's also this commitment. We've been allowed through the grant to have this commitment to providing the whatever, you know, the need of the team in terms of education and you know, skill development, et cetera, to make sure that they are as successful as possible so that they can navigate between both the health system and community and all of these things, which I think is a whole nother question unto itself. What is that like for people, right? To be in sort of, not so much the middle, but sort of going in between all of these places, and what's that's like. But anyways, I just can't state enough how much I think having community, hiring from the community is really important.
And how about you, Kwong? Any words of wisdom about what some tips for doing this type of work in other locations?
So I think, that, a suggestion or recommendation, it would be like a location. So I know that DP or recommendation services, CCD, provide in-person like evaluation, like they come to the parent, to the family home to do um, intake or evaluation. When I think there's time when they cannot, like CCB cannot come to the parent, to the patient's home due to, some other factor. But if we have like a location where refugees patient, NANS patient can go to get the screening done, you know, ESQ done in that room, in that location, and then intake is done in that location, and evaluation done in that location, then I think we will see a increase in getting the child completed, getting the services, from the beginning to the end. And then because the other thing is, then the NANS patient, they don't have transportation. A lot of them have kid, kid and husband work, and then a lot of the time they can't really travel really far. So if we like I mentioned earlier, if we have like a location that near to where the community lives, then it would definitely increase the intake or evaluation rate for sure.
Thank you. And we had another question. It said that I love that you're supporting additional training in these areas. Do those trainings include, or how might we better provide trauma-informed care? And I can speak a bit to our program. So we are always looking for new training opportunities, and which have included along the way lots of trainings through the patient navigator. It's, Betsy, correct me if I'm wrong. Is it the collaborative? They keep changing. Training collaborative.
I'm sorry, I just missed that.
Oh,
Sorry, what was
sorry.
the question?
The patient navigator training collaborative. Is that what it is called still? It's changed a couple times.
No, well, I mean, part of it, the training piece is sort of called that, but it's really called the Alliance now, but yes.
Okay, I knew I was going to pick the wrong word. As
fine. No, you're fine.
As everyone on the panel will say, I'm good at picking the wrong word.
No.
They've done a lot of specific trainings related to patient navigation through that. And then they have also all gone through mental health first aid, and then motivational interviewing as well. I was just asking Betsy in the chat about trauma-informed care, and that our team, beyond those trainings, and it's trauma-informed care coming into those trainings, has not done a specific training on it. And we would love to, if people have responded, Rocky Mountain have, in terms of how your teams have been trained in.
We have a few providers that have been able to access endorsements through COAIM to be working through reflective supervision, and as well as some trauma-informed care, I believe, as part of some endorsements that a few of our providers are going through.
Similar at Developmental Pathways, we have providers that have done the COAIM training and do reflective supervision.
Yeah.
Denver Health also has behavioral health providers, psychologists, and social workers, and so they've all done trauma-informed care training as well.
Mm-hmm.
Thank you for those answers, and thank you to everyone for joining us today. I'm going to pass it back to Eileen just to tie up a few loose ends.
Thank you to our panelists and our presenters. You guys just worked so hard in thinking through what questions could really help further this work for other children and families, and appreciate the thoughtfulness that you all put into preparing your answers. Our hope is that you all walk away with some concrete ideas of how to improve or implement developmental screening and referral processes to ensure equitable access for all Colorado's children. If any of the materials or other things referenced today, you'll be receiving a follow-up email from JFK Partners with my email address. So please reach out to me and I will reach out to our panelists to request more information or to answer any additional questions. So with that, thank you so much to JFK Partners being willing to sponsor this webinar for us today and include this in their work with children and families. So thank you, everybody.